Staff Participation in the Implementation of Electronic Health Records, presented by Kimberly Prue. Since graduating from nursing school in December 2004, I have been involved in implementation of electronic health records on 3 occasions. The first on a medical surgical unit, secondarily in an emergency department, and lastly in an urgent care and ambulatory care facility. The 2 experiences in of themselves were interesting to learn, but the most noteworthy aspect is the differences in programs that are required because of the differences in the populace of the 2 units. When it came time to execute an electronic health record in urgent care, I was approached to work as a super user to help with the program implementation. I had experience with Cerner FirstNet working in the emergency department, and this was the program to be implemented in urgent care. I conducted my interview with Karen Pawlowski, Clinical Manager of Urgent Care. One of the things we talked about was why Cerner FirstNet was chosen for urgent care and ambulatory care facility, when in actuality it is more an emergency department-based program. Karen explained that there are other programs that are more specific to ambulatory care facilities, such as NextGen and eClinicalWorks, but each had specific reasons for not being chosen. Karen goes on to explain NextGen's deviancies included the fact that it was costly and upgrades had to be made by staff, not information system support. And eClinicalWorks is more of a standalone program that would not easily integrate with other programs already in use. Cerner claims they are transforming healthcare by eliminating error, variance, and waste for healthcare providers and consumers around the world. Their solutions optimize processes for healthcare organizations ranging from single doctor practices to entire countries. For the pharmaceutical and medical device industries, and for the field of healthcare as a whole. Their solutions are licensed by more than 9,000 facilities worldwide. Karen states Cerner was ultimately put in place because Cerner's FirstNet program can be tailored to the specific needs of an ambulatory care facility, even though it is a program geared more from an emergency department. She uses a great analogy. Cerner is quite like a stick-built home in the sense that a room can be added and a door can be made to get into the house. Picture this. Cerner is the original structure, the home. Doctors order x-rays and need to be able to view them, so a room is added with a doorway, and the program RadNet is across the threshold. Now doctors would like to order and see lab results, but the lab program is not part of Cerner's programming. So visualize a propane tank called LabQuest being put into the yard with a gas line running to the home, which again is Cerner. Essentially what Karen is saying is that Cerner's interfacing capabilities is a main component of its strength when it is used in ambulatory care facility settings. The implementation of Cerner FirstNet was put into process in the urgent care clinic in 2007. I worked at urgent care as a charge nurse and had the opportunity to work as a clinical super user and tested for usability as the Cerner FirstNet program was being put in place. This enabled me to have a voice as a clinical user and offer input into the design adaptation of Cerner FirstNet. I will share with you the 2 biggest chores of converting processes from paper to electronic health records. The first being medication reconciliation, the slide you are now viewing. And the next slide shows the process by which the super users were taught to systematically enter medication information into the FirstNet medication reconciliation program. Each individual step had subcategories that had to be addressed. This was a very cumbersome process. The FirstNet program requires all medications that the patient has taken in the past 24 hours to be recorded under medications by history. Name, dose, route, frequency, PRN reason, and last dose are the minimum data required to complete the application. Viewing the screen, you can see that this is, as I previously said, a very cumbersome process. Ultimately, as you update the medication list, the screenshot will appear as this one does. If it does not, it will not let you continue until you have addressed everything appropriately. I mentioned there were two big chores when it came to converting information from paper to electronic health records. Shown here is the second. As difficult as this particular area was to accomplish, it was also probably the most entertaining. If you look at the top of the screen, you will see a view of the grease board. This is essentially what you watch and work from. It provides you with all kinds of information from what room a patient's in, how long the room has been occupied, the patient name, date of birth, if that patient is male or female, a short synopsis of the complaint, patient allergies, comments, encounters, orders, type of provider, acuity, and HIPAA status. The next three slides show where we all had a bit of fun picking out the icons that pertain to an encounter or a task that needs to be completed by staff. A few are pretty self-explanatory. The pelvic setup icon was a hoot to develop, as you well can imagine. There are even some secret icons, such as the camper icon, which signifies that there is a prisoner in that particular room. The next two slides show what nurses are never caught without, their nursing tip sheets. These were basically cheat sheets. If you forgot how to fire an icon, the sheets would remind you. If you forgot what an icon represented, or how to fire an icon showing the encounter was in progress, etc., the first few weeks these sheets were invaluable because they were referred to often. Again, this slide just reiterates what the working grease board looked like. This is the heart of the FirstNet program. This is how the staff knows what kind of interventions the patients need. There would be time that downtime is planned, and if this was the case, we would receive ample notice to prepare in the form of an email bulletin. But there were those times of no notice. I can remember when we first initiated electronic health records, we would all pray for downtime, because we could go back to our old ways when we were comfortable with our procedures. We would go right back to clipboards and paper charting. But, as we all know, a good thing cannot last forever. FirstNet would once again be up and running. Any charting would stay in paper form, but any orders would have to be caught up and put into the system. Turns out, oftentimes, this was a lot of work depending on the length of downtime. And we eventually got to the point where, if it were downtime, we were upset because we had become acclimated to the computer system and enjoyed that so much more than paper charting. These last two slides, I thought I would share with you some of the hurdles that had to be overcome while implementing FirstNet into urgent care. Some of the fixes were relatively simple, such as anything involving user entry error. Other fixes were not so easy, such as getting the part-time providers' names on computer-printed prescriptions. I asked Karen what she expects to see in the future. What will trends of electronic health records be in years to come? She mentioned two specific things. One is meaningful use. Her thoughts were that information systems will improve and also become more exacting. For example, at this point in time, it is required that all children under the age of 14 must be weighed and that weight be documented in the electronic health record. In the future, it will be required to determine body mass index on all patients and to document that in the electronic health record. The second future trend Karen mentions is International Classification of Diseases 10th Revision, ICD-10. Karen explains that ICD-10 necessitates more exacting coding, and this will be a very difficult process. Instead of the basic description of what the patient's diagnosis is, example fusing the joint of the big toe, the ICD-10 will require an exacting diagnosis such as hallux, rigidus, ankylosing. She goes on to say it will be very difficult to fill the position of coder simply because there is not an exhaustive supply of persons working in that field. Thank you for taking the time to review this presentation. I hope if any of you have the opportunity to help implement a program, you would choose to do so. It is a rewarding challenge. When I looked at that grease board every day, I was proud to know I helped create it.